Well, thank you, everyone. It is our wonderful noon hour where we get to learn from our amazing experts and colleagues in the field. Today, it's thank you. I just want to say thank you, Dr. Steiner, for being so patient and as we transition to deal with our technical difficulties this today. So without further ado, Dr. Steiner is a Charles A. Dana Professor of Psychological and Brain Sciences at Colgate University, where she has taught since 1999. She received her PhD in clinical psychology from the University of Minnesota, and her research centers on personality development in children, adolescents, and young adults, including stability and change in personality traits and the influence of personality on positive life outcomes and the emergence of psychological disorders, especially personality disorders. She was included in Princeton Review's Best 300 Professors and was a consultant to the work group on personality disorders for DSM-5. It's such a pleasure, and I'm going to be quiet now so we can go ahead and listen, and I'll pass the mic over to you. Thank you so much for being here and everyone else.
All right, thank you so much. So I'm gonna go ahead and share my screen. All right, well, hello, everyone. I'm glad that you made it here. Despite the link troubles, I'm really glad that you're here. So again, my name is Rebecca Scheiner, and I'm going to be talking about the emergence of personality disorders in adolescence. And I'm going to highlight new findings and end with the implications for treatment. Before I start, I wanted to say a little bit briefly about how I ended up in this field of personality disorders in young people. My area of expertise is personality development, normal range personality development in terms of temperament, personality traits, and so on in children and adolescents. And around 2004, I got invited to a pre-planning meeting for a DSM-5 for the personality disorders chapter. So even though DSM-5 didn't come out until 2013, the pre-planning started in around 2004. And I got invited to this meeting despite the fact that I knew nothing about personality disorders. And it was clearly an indication of sort of the desperation that the planners were feeling, that they included me because they hoped that my expertise in normal personality development would be helpful as they set off on planning the personality disorders revision. So in the time since then, I've become very committed to this area of work, and I really see it as one of the most important areas of research in young people. So here is what I'm going to talk to you about. And first, I'm going to be using the abbreviation PD throughout for personality disorders. So I'm going to be making the case for the existence of personality disorders in adolescence. I'm going to start with that just because I think there are still some misconceptions about that. And then I'm going to be spending most of the time talking about how personality disorders emerge from normal range personality processes that go awry in childhood and adolescence. And I'm going to end by talking about the clinical implications. So I'm going to tell you my two takeaways now, and I'm going to come back to them at the end too. So these are the themes that I want to hit on and that I really want you to come away with. So one is that adolescence is an absolutely critical period for the development and the manifestations of personality disorders. Even though they may have roots even earlier, you may be able to see some earlier signs of them in childhood. It's really during adolescence where these tendencies become exacerbated typically, and where they begin to cause the kind of impairment that can lead to the persistence of personality disorders over time into adulthood. So we're going to talk about why adolescence is so important. And then second, I'm going to outline the ways that normal personality development contributes to the emergence of personality disorders. So in other words, we don't have to turn to some sort of exotic, unfamiliar processes to make sense out of where personality disorders come from. We need to just look at the existing literature on individual differences, personality differences in young people, and to make sense out of the pathways that lead to personality disorders. Okay, so I'm going to start by just clarifying what a personality disorder is. The perspective that I'm going to be taking throughout this talk is that the categorical personality disorders that were retained in DSM-5, so examples like schizotypal, borderline, narcissistic, are in general less useful to clinical work than a kind of deeper understanding of what really constitutes a personality disorder. And I will say more about the problems with these categorical diagnoses at the end, and we'll introduce the alternative models. But I want to begin by just highlighting, so what is it that really constitutes a personality disorder? What really makes it different from all the other disorders in the diagnostic manuals? So in ICD-11, which is newly out, and DSM-5, in the alternative model for personality disorders, they're conceptualized as being disturbances in two big areas. So the first is in aspects of the self, and the second is interpersonal dysfunction. So first, in terms of the aspects of the self, what characterizes a personality disorder would be problems, for example, with identity, where the person has a very unstable or incoherent sense of identity, an identity that may be changing, an identity that's not really grounded in kind of basic values or goals that the person has. There are difficulties often with self-worth, where the person may tend to see themselves in a very black and white way. This relates also to the accuracy of the self-view, which is often distorted and not really in line with how other people may perceive the person. And then finally, problems with self-direction in terms of having a sense of goals and with being able to sort of chart your course through life. Then second, relatedly, would be interpersonal dysfunction. And so we see this in terms of difficulties with developing and maintaining close relationships with other people, difficulties with taking others' perspectives, challenges with empathy, tendencies to manipulate other people, difficulties with managing conflict. There's pretty good evidence that it's the self problems that drive these interpersonal dysfunctions, but often it's those interpersonal problems that are kind of the clearest and first manifestation of a personality disorder. Carla Sharp has this beautiful paper. If you're interested in this area, I strongly encourage you to read this. It's in the Annual Review of Clinical Psychology in 2021. It's called Refocusing Personality Disorder on What It Means to Be Human. So the idea here is that personality disorder reflects some fundamental disturbances in terms of what are the most human processes in terms of having a strong functional sense of self, and again, an ability to relate to others. So in this paper, Sharp defines a personality disorder as being a general adaptive failure of a subjective intrapsychic system that's needed to fulfill adult life tasks. What in the world does that mean? What that means is, so the subjective part has to do with the person's lived, felt experience of being that person. The intrapsychic system we can think of as being the mental representations that the person has, the way that they perceive themselves and perceive other people, and then the representations they have for themselves in relation to other people. And then finally, if this is disturbed, then it's going to interfere what we think of as being kind of the life tasks of adulthood. And I tip my hat here to Freud, this classic idea that to be an adult is to be able to love and to be able to work. And so if this self and other system is disturbed, it's going to interfere with that. And we can think of this subjective intrapsychic system as being on a continuum. that ranges from healthy at the one end to severely impaired at the other. And so on the severely impaired end, we see things like tendency to be preoccupied with being rejected, being terrified of social ineptness, feelings of inadequacy, anger, the identity disturbances I was mentioning, and even paranoia. And there's good empirical evidence that that extreme end of personality dysfunction is really represented by the kind of symptoms that you see in borderline personality disorder. Okay, so that's really what a personality disorder is. You can just really boil it down to this dysfunction in the intrapsychic system that kind of makes up the sense of self and other. So now I want to talk a little bit about that conception from a developmental perspective. So for a long time, we knew very little about personality disorders in young people. This is why I got invited to a meeting for pre-planning for DSM-5, is because there was so little work at that time. And the reason that there was very little known for a long time, I believe, is that in part because the diagnostic manuals themselves have been ambivalent about the presence of personality disorders in young people. What they say is that you can diagnose personality disorders in people under 18 only in, quote, relatively unusual instances. And yet there's this weird contradictory statement that follows that says, but they have their onset in adolescence or early adulthood. So they begin, during adolescence, but we can't diagnose them. But I think that there are other reasons that there has been, a lack of research. Coming from, I think, genuinely positive motivation, which is a desire to protect young people from what has been seen and still, unfortunately, is seen as being stigmatizing diagnoses. So people correctly perceive personality as being under construction. And I'm going to be saying a lot about that in a bit. It is absolutely true that people's personalities are still under construction in adolescence and continuing into adulthood. And there are also assumptions that a certain amount of personality dysfunction is normal in adolescence. There's the classic idea of the storm and stress model of adolescence. So people have been hesitant to apply these potentially stigmatizing diagnoses to young people when perhaps the problems are transitory and perhaps they're not really meaningful. And I will say more about that in a bit. Interestingly, in the newer models in the DSM-5, there is no age restriction offered, and that is also true for ICD-11. They removed the age cutoff of 18 from ICD-11. So because of this cutoff for such a long time, we just had very few data on personality disorders in young people. So there are some data, and the pace of publication in this area has been increasing incredibly rapidly. So there was a 5-fold increase in research on borderline personality disorder, for example, from 2004 to 2014, and the pace has picked up exponentially really since then. We also know quite a bit about the precursors to antisocial personality disorder, and that's because the diagnosis has embedded within it a developmental description of what it looks like. Also, there's been a real lag in treatment outcome research for personality disorders in young people. But there's been a tremendous increase in that over the last 5 years or so. And one really problematic outcome of this rejection of the idea of personality disorder in young people is there's a strong potential for misdiagnosis, because if you are avoiding these diagnoses just as a whole, then you may find yourself going to other diagnoses that may not be appropriate. So for example, young people are sometimes diagnosed with bipolar disorder when that may not be really the problem that they are having. And there's some evidence that clinicians will tend to not give these diagnoses even when a young person meets all of the criteria for them. Okay, so now I'm going to very quickly make a case for the existence of personality disorders in young people and a case for why they are so important to consider. So first of all, in terms of the prevalence, The data aren't as good as we might like, but there's pretty consistent evidence that in terms of prevalence, at least in the US, that the prevalence rate is somewhere around 11%. And that is coincidentally just about the prevalence rate in adults. So it seems to be as prevalent in young people as adults. And it may in fact be most prevalent earlier in adolescence. In addition, there's pretty good evidence that personality disorder has enough stability to be worth considering in adolescence, even though there's still good evidence for its changeability. So in terms of rank order stability, that would be the correlation of personality disorder symptoms over time. There's good evidence that the stability, the correlation is somewhere in the 0.4 to 0.65-ish range. So that's pretty good stability. There's also evidence that there's mean level change, that meaning that on average, there is a tendency for personality disorder symptoms to increase in those early adolescent years, and then to, on average, decrease later in adolescence and early adulthood. So in other words, personality disorder symptoms, if anything, are at their strongest in those adolescent years. And then finally, though, in terms of the stability of personality disorder diagnoses in adolescents, just as in adults, the stability is actually quite modest. And that is because if a person, say, loses or gains a symptom, they may lose or gain the diagnosis. But the more important thing is that the symptoms themselves often show some stability. In addition, there's good evidence that personality disorders in adolescents are serious business. And the citations I'm going to use here are all pretty old. And I'm doing that on purpose because it demonstrates that we've known this for quite a while. So for example, in terms of the risks posed by personality disorder, there's evidence that they pose risk for a greater rate of violence, greater rate of suicide, and other risky behaviors, for poor achievement of later developmental tasks like developing romantic relationships or establishing a work history. Also, there is a kind of cyclical process where poor achievement on those life tasks predicts the tendency for personality disorder symptoms to worsen over time. So if a young person is having struggles with personality disorder symptoms, and that's getting in the way of building relationships and learning to work and so on, that impairment is going to tend to worsen the personality disorder symptoms as the young person moves into adulthood. Interestingly, there's also great evidence that adolescent personality disorder is just as predictive as other non-PD disorders of future impairment. So these disorders are as problematic as any others. And then finally, the more persistent that personality disorders are in adolescence, then again, the worse the outcomes tend to be in adulthood, which suggests that there's an important role for addressing these conditions earlier. Okay, so to pull all of that together, we have a pretty clear idea, I think now, of a picture of personality disorders in young people. So they clearly are prevalent and they're moderately stable by the time we hit adolescence. And although personality disorder symptoms improve for some adolescents, for others, the outcomes can be quite serious, and the patterns often will become established during this period of life. So adolescence is really a critical juncture in the development of more persistent personality pathology. So this all makes a good case for why it's so important to figure out what are the personality processes that are involved. And so that's where I'm going to turn in just a minute. Before I make one other point about this, which is that young people themselves recognize that personality disorders exist. And this has been a big change, I think, just over the last few years. I think there used to be a lot of questions about how do you explain to a young person that they might have difficulties with personality disorders, but probably many of you know that there's been a kind of a spread of people, young people posting on TikTok, describing themselves as having borderline personality disorder. We can talk later about whether this is good or bad, but the reality is that it's out there in a way that I don't think it ever was really in the past. So I think more young people are aware of at least what borderline personality disorder is. And it's also represented much more in terms of, I think, just the media that are out there. So just as an example, I've been watching through Crazy Ex-Girlfriend the last month or so. And about a couple of episodes in, I thought, I think she's got borderline personality disorder. And I Googled it. Probably a thing I shouldn't do, but anyhow, turns out it's revealed later in the series that in fact she gets diagnosed with it. So there's representation of these conditions, I think, in places that young people are going to be much more exposed to than in the past. Okay, so now let's talk about the emergence of personality disorder from more kind of typical normal range personality processes that are relevant to all young people. And I'm going to talk a little bit about how these processes might go awry. So in other words, we can draw on existing research on these normal range personality processes in order to explain how personality disorder emerges in adolescence. And I'm going to be using a personality model that is developed by Dan McAdams. That is a comprehensive model for personality differences. And I actually originally applied this Dan McAdams model in a paper in 2009. And so it's been really exciting to see people take it and then use it to explore some of these processes in young people. And I also wanted to mention that I just wrote a review paper on how to assess these normal range personality processes. So you can refer to that if you have interest in learning more about how to assess them. Okay, so what is the model? So Dan McAdams makes a very compelling case that we can think of personality as having 3 levels that emerge in sequence across the course of our development. And so the first stage that emerges is the person as actor, and these are our personality traits. These are consistencies in our personality tendencies that are consistent across situation and time. And then at the next level, when we get a little bit older, around the age of 7 or 8, we develop personality differences that reflect our tendency toward agency, which is our attempts to go out into the world with goals that we have, with values that we have, with our particular ways of representing the world, and to pursue that as an active agent. And then finally, this last layer, the author, is the emergence of narrative identity, which is where we begin to tell to ourselves and to other people the story of our lives. And that story that we tell has immense implications for our mental health. So I'm going to work my way through each of those levels. And I did want to mention, if you're interested in learning more about Dan McAdams' model, he has a terrific book that is on the left there, The Art and Science of Personality Development. There's also a handbook that Dan and I and Jennifer Tackett published a few years ago where we use this model. And also Dan has a fantastic Atlantic piece that was analyzing Trump's personality using this model back in 2016. So that's an easy way to explore the model online. Okay, and because we got started a little bit late, I'm going to actually skip my case example. I just want to make sure we have time for questions. Okay, so that first level is the person as actor. These are our personality traits, and you can think of this as being an actor in the sense that these are readily observable by the important people in our lives. So these traits are the tendencies that we have to be to behave, to think, to feel in certain ways across situations and across time. And this is the earliest part of our personality that emerges, and it emerges in terms of temperament, from birth, although the stability of temperament is very, very low early on. So we show temperamental differences in these traits, and then they begin to kind of expand and take the form of the big 5 personality traits by middle childhood. So I'm guessing that many of you, most of you, have some familiarity with these 5 traits. So here they are. So there's extroversion, which has to do with how sociable, how expressive and energetic a person is. There is neuroticism. This is another nod to Freud, that reflects a person's predisposition toward all kinds of negative emotions like anxiety, sadness, etc. Conscientiousness, which has to do with our differences in impulse control, planning. Agreeableness, which is a profound interpersonal difference in terms of how much you are tending to be kind and flexible and empathic, versus being more hostile, cynical, aggressive. And then finally, openness to experience, one of my favorite traits, but the least relevant for personality disorders. We know that these individual differences in traits are shaped by both genetic differences and environmental experiences. And what's really important for this talk is that these personality disorders are characterized by a tendency toward extremity, particularly on a subset of these traits. So interestingly, the research on these personality traits parallels the findings that I mentioned earlier for the stability and change in personality disorders. So for traits, there's moderate rank order stability by around age 3, although, and I can't emphasize this enough, traits, like nearly everything about young people, do change over time. So there's enough stability for them to be meaningful and enough change for them to be a good target. We also know that these normal range personality traits actually show a pattern very similar to what we see for personality disorders. So in terms of traits, what happens is neuroticism, for girls at least, increases in adolescence, and then on average will tend to decrease in young adulthood. And also relevant for personality disorders, agreeableness and conscientiousness reach their nadir in adolescence, and which always strikes me as a finding that is completely obvious to anyone who has spent time with young people. But yeah, so that's the age where people are the least planful, the least empathic, etc., across the life course. And what makes this really relevant to personality disorders is that personality disorders often involve a combination of high neuroticism and low agreeableness and conscientiousness. So the finding that personality disorders are kind of they're most prevalent in adolescence maps onto the findings for these traits. Some young adults don't show those positive personality changes that tend to emerge in later adolescence and young adulthood. And that's especially true for people who are not getting normative experiences with adult roles in terms of friendships, romantic relationships, school, and work. So there is pretty good evidence that these traits interact with adversity in a way that leads to potentially the worsening of these tendencies over time. So there's good evidence that kids who are more neurotic, less conscientious, less agreeable, tend to experience more adversity and more stress in adolescence, partly driven by their own behavior, because they are going to be tending to get into fights with other kids. They're going to be tending to not get their homework done when they're supposed to. They're going to be more likely to be arguing with their parents, and driving kids away because they seem very sad. And so those stressful experiences that they generate for themselves turn around and tend to predict more negative changes in those same personality traits. And I'm not going to go through this in too much detail because I want to make sure we have time for questions. But I published some data a few years ago demonstrating this, basically demonstrating that adolescents who experience higher levels of adversity during adolescence, when it's related to their own behavior, they tend to increase in neuroticism, and they tend to decrease in conscientiousness and agreeableness over time from childhood to adulthood. So again, there's reason to believe that when young people generate these stressful experiences for themselves, that they tend to experience some negative personality consequences. Okay, now on to the second level, the person as agent. So you can think of this as the goal-directed person who is trying to make sense of the world and trying to accomplish things in life. So these are the personal concerns that individuate one person from the next. So again, you can think of the person as a motivated agent in terms of the goals that they have, their values, their mental representations, and also the coping strategies that they use to try to get what they want. So these are different from traits, and that traits tend to be somewhat more consistent across situation and across time, whereas a lot of these personal concerns are much more specific, say, to a particular domain of life, whether you're thinking about your mental representations of friends versus romantic partners, or they tend to be specific, say, to a specific role that you're in as a student, for example, or to a particular developmental period. So these tend to emerge in much clearer form around the age of 7 or 8, when kids begin to be able to formulate their goals for the future, their plans, and so on. So I'm going to give you a couple examples, one having to do with mental representations, and then the other one having to do with coping. So mental representations are the ways that young people perceive and think about themselves and other people. And there's huge variation in this in childhood, but increasingly so in adolescence. One really interesting line of research looking at these mental representations has to do with hypermentalizing, which is a tendency to sort of impute thoughts and ideas and motives to other people that are not accurate. They're not in line with reality. So there's been tremendous research on this in borderline personality disorder in adolescents. So here's an example of this. This would be an example of a young person engaging in hypermentalizing. So person A invites person B to dinner, but B replies hurriedly that she is unavailable because she has a prior engagement. A then assumes that B does not want to spend time with her because of a minor misunderstanding that she recalls from several years ago, where A did not turn up for B's birthday party. Did you follow all of that? This probably sounds pretty typical of, lots of teenage scenarios. And so this hypermentalizing is a tendency, to impute things to other people that are not accurate. There's lots of other great research on these mental representations in borderline personality disorder in adolescence. So, for example, demonstrating that teens with this diagnosis tend to have overly positive or negative views of the self. They tend to mistrust or to over-idealize other people. And they also have a kind of perfectionistic thinking or extreme black and white thinking. And these inaccurate, incorrect mental representations, they often will evoke very strong feelings in teenagers. And this is especially true as relationships become much more complex and just challenging to navigate. That as young people with some personality disorder tendencies are misrepresenting other people, misinterpreting things, that will often evoke a strong emotional reaction, both in them, within themselves, but also in the people they're interacting with. A second good example of the person as agent, individual differences in this has to do with coping strategies, which emerge in childhood. Youth vary tremendously in how they approach stressful situations, right? We all know this. But what's interesting about coping strategies is that there's a general tendency in adolescence for the kind of coping strategies that young people use to become less adaptive. So they pick up some new coping strategies that are not great. For example, rumination becomes much more intense in adolescence. Aggression becomes more heightened in terms of relational aggression. A tendency to blame other people is a preferred coping strategy for a lot of teenagers. And what's tricky for teenagers, especially younger ones, is that the more advanced strategies that many adults use for coping they don't come online until later, like learning how to strategize, learning how to plan, and so on. So there's good reason to think that young people who chronically use these poor coping strategies like avoidance may have a worsening of their personality disorder symptoms and may experience more impairment over time. Okay, so that's the person as agent. So we have the person as actor in terms of the traits, and then we have these newly emerging capacities for agency and individual differences there. And then finally in adolescence, we start to see the person as author. And so this refers to individual differences in what's called narrative identity. So narrative identity has to do with the stories that we tell about our lives that we use to reflect on, and then also to create a sense of personal identity. What McAdams has argued is that in the modern world, at least in Western cultures in the modern world, people are faced with this question of who am I? And they are faced with the question of how they are going to generate a sense of purpose and meaning to their lives, because they don't have a ready-made script or narrative that is handed to them by the culture. And I would argue that this has become particularly extreme at our present moment, where options are seemingly limitless in terms of the stories and the sense of meaning and purpose people may come up with. So construction of this story that we tell ourselves about who we are, it begins in adolescence. As Erik Erikson noted so many years ago, these narratives play a really important role in developing a sense of identity in adolescence. And it emerges in adolescence because it requires the kind of abstract thinking and the capacity to connect the past with the present, with the future, in order to create a coherent story. And young people they can't do this until that kind of Piagetian abstract thinking emerges in adolescence. So they have to connect their sense of themselves with specific memories, especially difficult negative memories. And then they also begin to have themes in the way that they narrate the stories of their lives. And I think it's useful to think about the way that this narrative identity differs from the conception of identity that a lot of young people increasingly have, in the sense that for a lot of young people, they are often engaged at this present moment in constructing a sense of identity, in part based on templates provided for them online, sort of categories that they can sort themselves into, whether they have any relevant life experience for those categories or not. And so I want to emphasize that narrative identity is as classically conceived, is different from that, in that it's the result of a protracted process that continues all the way through adulthood, where young people are engaging in kind of real life experiences, and then finding a way to create some kind of coherent whole or coherent story out of those experiences. So it's something where it's being constructed over time, as opposed to something where you sort of look at a list of options and say, oh, that's me. So in terms of the relevance for personality disorders, given the fact that personality disorders involve disturbed views of the self, it's very likely that personality disorders are tightly linked with these emerging personal narratives. So there's good reason to think young people with personality disorders may face difficulty where they may have had difficult negative life experiences, whether sort of brought upon them or experiences they've sort of brought upon themselves through the processes I mentioned earlier. And they have to find a way of taking those painful, difficult life experiences and then weaving them in to a more positive and functional story of the self. And this is a challenge for all of us, for any of us who have experienced something or a number of painful things. So young people with personality disorders may have struggles developing a more coherent life story. They may have trouble committing to a life path, which is, part of the nature of a personality disorder. And they may miss out on some of the benefits of having a more coherent narrative in that transition to adulthood. And it turns out that this kind of identity integration, creating a coherent sense of self, is one of the key ways that young people with emerging personality pathology differ from young people with other kinds of disorders like depression and anxiety. So just a quick example, there's been a big increase of interest in studying narrative identity in relation to personality disorders in both adults and in adolescents. So I was really lucky to be invited to participate in a study looking at narratives and their relationship with schizotypal personality disorder in adolescence. So this comes from a very large sample of Dutch teenagers where they were asked to write a turning point narrative. What that means is they were asked to think about a particular experience that they had that they felt had some lasting impact on them, had some kind of enduring impact. And then we looked at the relationship between the stories that they produced and the presence of schizotypal personality disorder symptoms. So just as an example, this narrative here on the top was produced by someone with a low level of schizotypal personality disorder symptoms. So my grandmother passed away about a year ago, and I had a lot of trouble dealing with this at the time. Things at school were also not going well because of this. I often sat alone in my room, and although I did not cry often, I was very sad because I spent so much time thinking about things like friendships, relationships, and my future. This brought me much closer to myself, and I learned a lot about myself. So you can see in this narrative, they're talking about a turning point, but it's one where they perceive themselves as having grown. You can see that it's a coherent story, right? And they're successfully linking what happened to them with the way that they're developing as a person. In contrast, this was a narrative produced by a young person with a high level of schizotypal symptoms. So I walked past a tree painting at school and was pretty sure I saw horses leaping out of it. I told my classmates about this experience and they thought I was odd. I was teased and bullied more often after that. Since then, I've been coming up with excuses to avoid going to school, right? So we don't see any sort of resolution here. We see this young person struggling with fitting their aberrant experiences into a narrative. You can see that they're not able to make sense out of what's happening to them. And I did want to mention I think this is on my other slide, but there's a researcher named Maisie Lind who has been doing really excellent work on narrative identity and personality disorders. And she's been looking at both adolescents and adults. So if you're interested in learning more about this field, I highly recommend her research. Okay, so we'll come back to my two takeaways, and I hope that I have convinced you of these by now. So first is the big theme that adolescence is a key period for the development and manifestation of personality disorders. And again, that is because there are many things happening in adolescence that put kids at risk and that may put them onto a pathway that becomes more entrenched over time. And so because of this, it's really important to consider the possibility of a personality disorder diagnosis with adolescents. And then second, I hope I've convinced you that we can look at normal range personality development to explain how it is that some young people are going to be more likely to develop personality disorders in adolescence. And to me, this is a very destigmatizing perspective because it emphasizes that these are personality differences we can see in all people. And there's the potential for getting young people sort of back on track. Okay, so in terms of clinical implications, I'm going to go through this a little bit quickly, and there'll be time to ask more questions. So I think that this whole perspective I'm offering here really pushes for a movement toward a more dimensional model of personality disorders. There's tons of evidence that they do not exist as the categories that we see in DSM-5. And as many of you probably know, the personality disorder work group for DSM-5 was working diligently on a dimensional model for personality disorder, starting with that meeting that I went to in 2004. But the American Psychiatric Association rejected that proposal, I think out of fear that it was too complicated and that maybe the field wasn't ready to move away from categorical diagnoses. So what happened was an alternative model for personality disorders was placed in an appendix. And it is, I think, a very rich model consistent with the perspective I'm offering here. It's a little bit complex. So ICD-11 has taken that model and has now modified it to make it a more streamlined model. So the ICD model of personality disorders has now completely gotten rid of the categories other than borderline personality disorder. And the definition is very consistent with what I presented at the very beginning of this talk. So a personality disorder in this model is an enduring disturbance characterized by problems in aspects of the self and interpersonal dysfunction. So again, we're back to that idea that what's distinctive about these disorders is this disturbance in the sense of self and in the sense of relatedness with other people. And again, I really believe these newer models are more consistent with the view of personality that I have presented here. In ICD-11, they also included descriptors that you can use to characterize the personality difficulties the person is having. And they did it taking the big five, but using the pathological variant of them. So for example, extroversion is detachment. Well, neuroticism is neuroticism. That was already the negative version of it. For low conscientiousness, we have disinhibition, and low agreeableness is dissociality. And then finally, there's one that doesn't map onto the big five, anakaxia. It's a combination of high conscientiousness and high neuroticism. So it's a tendency toward rigid perfectionism, of trying to control your behavior and other people's behavior, controlling situations in a very rigid way. So I'm optimistic that the developmental perspectives that I'm offering are going to find a home as people increasingly embrace these dimensional models. Okay, two quick final points. One is and I've tried to emphasize this, but I just want to say it one last time. Personality and personality disorders can and do change. And there's just more and more evidence for this. So here are just a few. One is borderline features are as unstable as depression in adolescents. I think that's encouraging, but it doesn't mean we shouldn't be paying attention to it. There's evidence that neuroticism can change in therapy, and in fact, it does. And as I mentioned earlier, personality can change as the result of other environmental changes as well. So the more, for example, that you can help a young person decrease the stress and adversity that they're generating for themselves, the more likely you are to see them begin to change in terms of personality in a positive direction. And then finally, in terms of treatment, I think it's possible to target all 3 levels of personality and treatment. So, for example, I think it's possible to work with young people to teach them new skills to help them manage the traits they have that are more challenging, and in turn, potentially to lead to some changes in those traits. And one of the newest models for treating personality disorders actually does exactly that. It targets the traits themselves. You can also address mental representations and coping skills. And one of the validated models for working with personality disorder in young people is mentalization therapy that directly, it's kind of a psychodynamic updated therapy that addresses those mental representations and coping skills. And then finally, I really think all of therapy, good therapy, has to do with helping people develop more positive life stories about themselves. And so there's such an exciting moment in working with adolescents where you can help them to develop a more positive life story as they're in the process of constructing it. And then finally, I would add that every young person and every human has some personality strengths. And so coupled with an attention to possible personality pathology can be this recognition that there are strengths that you can draw on with all young people as well. All right, thank you so much. And I welcome questions if we have time for that.
What a fantastic talk. I can't believe it. We pulled it off with just a few more minutes to spare. So we are a big group. There's 82 of us, and I'm going to look in the chat really quickly. There was a question earlier about the intersection of trauma and substance use. Dr. Guerrero, are you still with us and would like to ask your question?
Yes, I am. Can you hear me?
Yep.
Yes, go right ahead.
Yeah, so let's see, I just was kind of wondering, hold on, I got to go back to the question. Yeah, so I've done a lot of forensic work with adolescents, and I used to run an adolescent treatment program for a large county. So I guess I've worked with different populations. And so I think there were reasons why, many reasons why clinicians were loath or hesitant to I hate to say, label someone with a particular diagnosis that could be enduring, because in a lot of those cases, in-depth psychiatric histories were not done. And so many diagnoses were missed and symptoms were not considered that really could have affected the diagnosis. And so I think I just was wondering what you've seen clinically, in regard to the populations that you've worked with.
Yeah, I think so.
Those diagnoses stick in a lot of these cases,
right.
Even though they're not even accurate. Many are.
Right. I think it has been common, for clinicians, rather than applying a personality disorder diagnosis. I mean, with the exception, I would say, of borderline, which is sometimes used, is to describe personality problems that young people might be having. And I would say that ultimately it's those personality processes that are the best target for treatment anyhow. And so, I mean, I guess I would say this is not what I've seen, but this is part of what I think would be useful clinically, would be to consider a personality disorder diagnosis, but not a specific categorical one. And then to provide a rich description of the young person's personality in terms of the kind of processes that I was describing here, because those are the processes that are going to be targeted in treatment. And on the issue of stigma and sort of the persistence of diagnoses over time.
Well, what about drug use too? I mean, adolescent or latency age. I mean, I'm just wondering, oftentimes there could be a dual diagnosis.
Oh, definitely.
And there also could be an axis 1 diagnosis as well. So there could be multiple diagnoses.
Right. Right. It would be, I think it's unusual for a young person to have a personality disorder and nothing else. And I think that's borne out by the data. So it's nearly always accompanied by other non-personality disorder problems in terms of depression or anxiety or substance use and so on. I think when you think about how pervasive the impact of these personality processes are on how a teenager is doing, it's not surprising that it would lead to all kinds of other psychiatric problems as well.
Right.
And just as a kind of, this is not what you're asking about, but I can't help but mention this, there's all this interest right now in the increasing rates of depression and anxiety in young people. It's been all over the news. Jonathan Haidt has been writing about this. And there's data that just came out showing this increase in rates of anxiety and depression. What I would be really interested in is whether, and also suicidality. And what I would be really interested in is whether that may be driven by changes in basic personality functioning, these self and other processes, as a result of the pervasive role of social media in the lives of young people and sort of living their lives online. My hunch is, from the young people I know, that it's maybe having these rippling effects on their emerging sense of self and other, and that the data on depression and anxiety may be missing the processes that are really driving some of the problems that young people are having.
Yeah.
Thank you for that. I am very sorry that we don't have any more time left, and I want to respect your time, Dr. Scheiner. This has been such an amazing talk, and definitely lots for us to think about and digest, and maybe request that you come back. So really appreciate your time and everyone's time here today. It was a full house. Thank you everyone for your patience and flexibility as we got on today. And please be safe, take good care. And Dr. Scheiner, enjoy your beautiful New York weather.
Yeah, thank you so much.